Well, we are excited to kick off Friday with a Symposium number 4, Gun Violence as a Public Health Crisis. We have a wonderful panel assembled, and this panel is moderated by Jim Fickey and Anna Miller, and I'm going to ask Jim to come up and get us started. And there will be time for questions, as we always have at the end of this, so save your questions, and we look forward to a great symposium.
Thank you, and thanks everybody for being here. I'm Jim Fickey, and I am the chair of at Johns Hopkins, and I've been the privilege to really moderate a session here with 3 other partners, friends, and colleagues that I just want to give brief introductions for, and we'll do this at the start, and then each of our speakers will step up. Can we move to the next slide, please? I don't think this, there, no, there is an intro slide. Okay, well, let me start from here. We can flex to this. Our first speaker this morning is Dr. Anna Miller. Anna Miller is a professor at Washington University and is a trauma-trained specialist. She has been the chair of the orthopedic section of the Committee on Trauma. She did her fellowship in trauma at University of Washington at Harborview. Thank you. And has been a leader in not only trauma and disparities affecting trauma in orthopedics, but also in this space that we're going to be talking about today with firearm violence. Our second speaker will be Jason Streslau. Jason is Canadian. He trained in British Columbia, and then he did his residency fellowship or his trauma fellowship in Edinburgh, Scotland, and is now at University of Chicago on the south side, and is the director of orthopedic trauma there at a very busy trauma center in Chicago. Joe Saccharin is an associate professor of general trauma at Hopkins with me, and we work together often on our weekends when we have gun violence that affects all of us. And Joe is going to give a lot of his own recollections and his own introduction by his request. So with that, I'm going to hand this to Anna, and thank you all again for being here.
I would second that. Thank you all for being here, and special thanks to Chuck Goldfarb and the Critical Issues Committee for really having the courage to put this on. So my talk this morning is on the socioeconomic disparities related to musculoskeletal injury, and I'm going to use St. Louis as a case study, but we know these are similar issues in many cities across the country. So I don't have any specific disclosures relevant to this talk, except that I do live in St. Louis. So we'll go over some history with St. Louis as an example, go over homicide and suicide by firearm a little bit, and some studies that we did on firearm injuries during COVID and socioeconomic disparities in musculoskeletal injury. So a little bit of history. If anybody has free time, interested in doing some more reading, I would highly recommend these 4 books. They're really fascinating, a lot about our history. And I'm actually going to focus on this one. It's called The Broken Heart of America, and you see the subtitle is St. Louis and the Violent History of the United States. And again, this is a case study about St. Louis, but really applies to many of our cities. But unfortunately, the fact that this book exists probably shows you that we have a very severe history in St. Louis. So in 2015, our city kind of realized we had some of these issues, and Washington University and St. Louis University, which are the 2 main academic medical centers, came together and created this handbook. And the subtitle, that's really small, so I'll read it. It says, "A Report on the Health and Well-Being of African Americans in St. Louis and Why It Matters for Everyone." So they created this book, and I'm showing you this because I'll reference it several times in the talk, but it is free online if anybody's interested in seeing more. So a little bit about St. Louis. For those of you who are planning for the annual meeting next year, this is where we are in the center of the country. You can see we're kind of right on the Missouri-Illinois border, and if you zoom in, We're really right along the Mississippi River between the two states, and here is the actual city itself. So if you type in Google Maps and look up St. Louis, you'll get this. And the star there is actually where our hospital is. But if you kind of zoom in on the details, this is actually the city of St. Louis. It's a really, really small part of the entire area, and our population is about 300,000 and unfortunately declining over time related to some of these issues. And this is kind of the greater metro area, the St. Louis County, we call it, which is about 3 million people, and it's actually one of the wealthiest and safest areas in the country. But when you hear statistics about St. Louis that you may hear about gun violence in particular, it's really concentrated in that smaller population in the city. So some of this comes from our history in the United States of segregation after the Civil War. Many of you know about this, and this is a focus of these two books, where we had the Great Migration, where especially African-American families migrated from the south up to the north, and they often came to cities where they already had other African-American populations or families. And once they arrived in these cities, they experienced a lot of segregation, being put into certain areas, having redlining where they were not able to purchase property or their property was devalued by our system, and then the white flight to the suburbs, which you can see very starkly in our area. So that history kind of led to many of the disparities that we talk about today. And in St. Louis, we have something called the Delmar Divide, which I'll talk about a little more in a second. But basically, if you look at this map that I showed a minute ago, there's a line, and this purple line right above our hospital, the star, is the street Delmar. And when you look at this PDF that I was talking about a minute ago, you see that if you look at this line, this is a map of zip codes and life expectancy. And north of that line, you have a 20-year fewer life expectancy than south of that line, just by living slightly farther north. And when we look at this in more detail, if you can't read these numbers, the home values north of that line are $78,000 on average, income of $22,000, 5% have a college degree, and 99% are African American. Whereas south of that line, home values are $310,000, income of $47,000, 2/3 have a college degree, and 70% are white. And this was almost 10 years ago, but it hasn't really changed much since then. So huge discrepancies. And what we know, actually, is that a lot of these discrepancies are related to the other issues we see. So this is a paper from 2019 where they showed the average index of dissimilarity, so more segregation is to the right on the graph, and on the y-axis is more black versus white firearm homicide. And Missouri is up here in the upper right corner, where we have a high amount of segregation, and that strongly correlates with a high amount of homicide. And we know gun deaths in our country are extremely high compared to all other developed countries. So some of these things are certainly related. So I wanted to start with just a couple of audience response questions. If you all don't mind getting out your phones, you can just take a picture of this QR code. And the question is, how many people die from gun-related injuries in the US each year? All right, so the vast majority, about 2/3 of you said greater than 60,000 people. So the correct answer is actually a little lower than that. We have about 48,000 in 2021. It's probably a little higher now. But just keep that number in mind. So almost 50,000 people die from gun-related injuries in the US each year. And I have one more question for you guys. What is the most common cause of death from gun-related injuries? And the options are homicide, suicide, or other. All right, I'm impressed. You guys said suicide. So about half of people said suicide, 1/3 said homicide. So suicide is the correct answer. And you can see on this graph about 54% of gun-related deaths are from suicide versus 43% from homicide, a few of them from other reasons. So this is just something to keep in mind because we all hear a lot about these mass shooting deaths, and they're clearly a tragedy, and there are way too many of them. But the FBI defines this as one or more individuals actively engaged in killing or attempting to kill people in a populated area. And in 2021, which is the most recent year they have data, only 103 people died from mass shootings. So this is definitely not to say that these aren't important, but it is really critical for us to remember that most gun deaths are not those mass shootings that are so widely advertised in the news. And if you look at this, it's kind of a complicated graph from a paper from Washington Post from a couple years ago, but the black bars are homicide and the blue bars are suicide. And you can see that the homicides are, the vast majority of them are the younger black male population, and the vast majority of the suicides are the older white male population. But suicides, even though the bars are smaller, the white male population is much larger, so we have many more suicides than homicides. And that's something to keep in mind because we know that people are much more successful at completing a suicide attempt if they have a gun available to them. So I want to go back a little to our Missouri gun law because it kind of is interesting to see what happens with these changes in law. So in Missouri, in the early part of the 20th century, anybody who wanted a gun always had to go to the sheriff's office, apply for a permit, have an interview and a background check, and get a permit to purchase a gun. So PTP, we called that. In 2007, they repealed that law, so anybody could get a permit to get a purchase of a gun without getting a permit. And then in 2014, we decided even that was too restrictive, so they put in new legislation to allow open carry, so anybody could carry a gun if they had a concealed weapons permit. And then in 2016, which is the year I moved to St. Louis, they put in permitless carry legislation. So you don't have to have a permit to carry a gun or a concealed weapons permit, and they enacted stand your ground laws, which some of you may have heard of as castle laws, which are basically being able to defend your own property if you feel threatened. So all of these laws really affected what we see, and when we looked at it, what we saw is that there was a 23% increase in firearm homicides after these repeals, even though there was no change in other homicides during the same period. And suicides also increased greater than all states combined that retained a permit to purchase law. So we have many, many more suicides than other states. And this is a graph from this Dying of Whiteness book. That black line at the top is the Missouri line, which you can see is increasing over time, but also much higher than many other states. So it's just something to think about how these things impact us. And we noticed a huge increase of gun violence during the pandemic, so we actually looked at this, and we studied Area Deprivation Index, which, if you haven't heard of this, is a zip code localized index where they look at the region's socioeconomic conditions and how those are linked to health outcomes. And there are a bunch of different things that they look at, but basically you can tell how deprived an area is down to the 9-digit zip code. And when we looked at this, obviously we see these same discrepancies with the Delmar divide that I talked about earlier. And in our graph, this is from the paper, you can see those red highlighted areas are where our gun violence is localized, and it corresponds completely with the deprivation index being very low. And this is also a graph from the paper that just shows that during the pandemic, we had a 60% increase in gun violence, and that probably also relates to the same disparities and discrepancies that patients have, along with the segregation I mentioned earlier. So something else to keep in mind with these is that they're correlated with a lot of other things besides health outcomes. So this is from that same paper. This is the availability of quality, nutritious foods. So people having grocery stores that are available to them, much more areas that have poor access in that northern sector. It also correlates with being African American, having more heart disease, having more poverty, and having more cancer. So we really have to keep all of these other things in mind when we're talking about our patients and gun violence and musculoskeletal injury. So we actually looked at this again using that same deprivation index and looking just at nailed tibial shaft fractures, a really common injury that we see. And in the patients who had the least versus most deprived areas, the gray is the most deprived, they had much worse patient-reported outcome scores in every domain, and they actually healed their tibias at a slower rate, even with taking all of the other factors out of the equation. So there are a lot of things going on with these patients that we have to keep in the back of our minds. So from this paper, we showed that social deprivation is associated with slower fracture healing, that it may also influence the patient-reported outcomes, and these disparities likely incur large costs to both patients and society. So we're really all affected by these issues. We also know that factors that prevent equitable and effective care really should be corrected. And that's something I'll go into a little bit more at the end. So hopefully I've summarized some of these basics behind firearm violence, including homicide and suicide, and the problems that we see. And I just want to remind all of you, and thank you to those of you who took the survey before the AOA meeting. This was one of the questions that we sent out that says, what is or are the roles that orthopedics should play in addressing gun injuries? And the vast majority of you were the bottom two, yellow and blue, which is advocacy in the community, community champions, regional or local government petition, or a national role with advocacy, voice of the patient, et cetera. So most of you want to get involved and understand that this is important. So we need to make sure that we're addressing many of these socioeconomic issues also for our patients. And then I just want to end with one of my favorite slides about obtaining full health potential. And this was similar to Val Lewis and Keith yesterday, kind of brought up some of these issues. But the differences in the definition of inequality or equality. So in this case, the inequality is the tree leaning over to one side and one child just gets apples falling right out of the tree for free. Equality is giving both of those kids the same ladder, which doesn't help the child on the side away from the tree as much as it helps the one that was already getting the apples. But equity is when you actually help the child that's a little bit farther away from the tree with a taller ladder to give them the resources they need to get to the tree. And justice, which is what we really should be striving for, is fixing those systemic issues, in this case, helping to straighten the tree so that everybody can get what they need. So thank you for your time, and I'll turn it back over to Jim.
All right. Well, I'm Jason Strelzo from the University of Chicago. I'm going to change gears a little bit and focus on some of the impact to the care team and the healthcare providers that are really in the trenches providing a lot of the care to patients who've suffered gunshot injuries. Disclosures, we do have some funding for some of the data that I'm going to talk about. And my primary disclosure is I'm not an expert in what we're about to talk about. I'm not a psychiatrist or a psychologist, but I think these principles kind of go across all of us. We can understand them without having to be experts in them. Lastly, my other disclosure is yes, I am a Canadian, so we don't see this as frequently, and it was an eye-opening experience for me personally. So I think everyone here has either read a news clipping or seen something with regards to Chicago. These are just some of the few that I picked out over the last few years. They're really highlighting just the sheer number of gun-related homicides and gun-related incidents that occur in Chicago on a yearly basis. I think Dr. Miller really did a nice job of highlighting the discrepancies here. This is something that you don't see published or looked at in any of these articles, and it's a troubling trend we see in Chicago as well. And as you can see with this slide, you can see the heat map of just where these homicides are occurring, and very similar to the Del Mar line. The University of Chicago sits right here. We did not become a trauma center until 2018. We had been a trauma center back in the 80s. And there was really a trauma desert in the south side of Chicago. If you were shot in the south side of Chicago in any of those red blocked areas, you had to travel sometimes up to 30 or 40 minutes to get to a level 1 trauma center given the traffic in Chicago. Our center opened in 2018, and really we had this massive flux of trauma patients. In our first year, we saw roughly 4,000 trauma activations, and uniquely to our center, almost half of them were ballistic injuries. So if you look across most of the other institutions across the country that are level 1, they see between 12 and 15% of their trauma is ballistic. In the summer months, we were seeing 50%. We've seen continual growth, about 30 to 40% year on year in our overall volumes. What this translates to on a daily basis is about 6 to 8 during the winter months, and upwards of 8 or 9 patients a day that we're treating that have been shot. In 2021, we saw a large spike as was outlined with the pandemic, and that spike has continued. In a weekend of call, it's not uncommon that you would see between 20 and 30 patients that we are asked to treat during the summer. So let's forget about the physical effects of what this trauma does, and let's talk about the other side effects. So the psychological effects of trauma are well known in terms of urban populations, motor vehicle accidents. The acute stress of having a trauma can have profound impacts on patients. But what's really not well described is how firearm trauma may or may not affect that. We currently screen all of our elective and trauma patients using a PTSD score. And this is just some of our preliminary data, but we have relatively good collection of this tool. It's part of our intake form in clinic and on the wards. And our pain score is roughly equal because that can play a role in PTSD and acute stress. And what we noticed was patients who'd suffered a gunshot-related trauma were significantly at risk for having PTSD. And when we looked at people who met the threshold for a diagnosis, almost 40% of our gun-related trauma victims had experienced and were experiencing symptoms of PTSD. These were substantially higher and significantly higher than motor vehicle accidents or other trauma mechanisms. But what about more broadly, right? That's the patient, but we have to remember that the patient doesn't live in isolation. We know that survivors of trauma and survivors of gun violence clearly are at risk for health discrepancies. And there's a bunch of theoretical models that may help to explain this, that the stress of the event may lead to disease and health outcomes that are disparate. A number of studies have looked at this predominantly across both indirect and direct violence. So if your family member or a community member was shot, this can also have ramifications for your overall health and your overall feelings of safety and security. We know that witnessing violence, and particularly witnessing gun violence, can have profound effects on how and the way you see the world. Many of these studies demonstrating substantially higher rates of depression, substance abuse, and recidivism. Even just having a neighborhood that's at high risk can have mental and social implications. And this study does a nice job of looking similar to the Area Deprivation Index, looking at areas that high rates of gun violence and the overall effects on health, such as cardiac disease and mental health admissions. So that's patient, that's family, but what about the physician team and the healthcare team that's looking after them? I'm going to start with this. This is a editorial from our chief of trauma at the University of Chicago in the New England Journal. He writes, "In reality, I harbor and carry the burden of suffering within me. The piercing screams, the severed limbs, the brain matter extruding from the temporal lobes haunts me. Many evenings on the drive home, I know that my inner battery is spent, that I have no more strength to shoulder the hurt. I have nothing left to give. Sometimes when I get home, I cry like a baby on my wife's shoulder. My wife, my 3 sons, my friends, and my faith. A belief in things not seen recharges me." So what is he explaining? What is he describing? This has been termed sort of secondary traumatic stress, or more recently termed vicarious trauma, originally coined in the early 80s. It's really when an empathetic bond with your patient who's experienced a trauma or comes in as a trauma victim stresses and leads to psychological impacts on the provider. I highlight cynicism because often that's the way it's most expressed by a lot of healthcare providers, because that's an easy defense mechanism when things get tough. In the news, we see these articles on a more frequent basis, or statements from things like the OTA describing moral injury, providers being overwhelmed, or really losing the capacity to provide care. When you look across other surveys of similar populations, young adults, both in high school and in universities, polled for the impact that they feel, not even involved in a mass shooting, but worried about the effects of a mass shooting, or the trauma nurses and the impact that caring for these trauma patients has had on them. We know from a lot of the European data, from some of the terrorist attacks, that from first responders who've been in the line of fire or taking care of patients who have been shot, there's high rates of PTSD in those providers. More distressing, however, is the bottom bullet that outlines that very few of those people who had acute stress reactions, who were experiencing PTSD, actually sought care. This is from our institution. We started this in 2018 when the Trauma Center opened. These are anonymized questionnaires for our providers, and you can see rates of things that are quite scary. Depersonalization in the 60% range. Burnout in the 50% range. Really important that burnout is not vicarious trauma. Burnout may make you at risk for it, but it is not the same. Burnout's really an overuse or overwork phenomenon. Work-related stresses that accumulate over time. Vicarious trauma is a single or multiple discrete events that present the same way as burnout, but are really focused on a single traumatic event. And they can coexist. Patients or people who are at high risk of burnout may be tipped over the edge when they have or experience a specific trauma. What are the risk factors for it? Well, these are the things we know, right? More exposure, longer exposure, repetitive exposure, those are bad for you. They lead to increased rates of vicarious trauma, burnout. Other events in your life, whether that's systemic hospital-related issues, personal issues, and then individual risk factors. We tread a very fine line trying to manage our patients, ourselves, and our families. There are some protective factors, and I think these are important to highlight. Certainly having a social support, a strong social support as a provider can be very powerful. There's some individual factors and then community factors, and I think these are the ones that are worth highlighting. At our facility, we have a violence prevention program. This program is a hospital-based unit that interacts directly with the patients, their families, and really tries to provide encompassing care to help those patients and their families out. This is just data from the first year of the program, but really demonstrating help with things like relocation, social support, employment support, and just helping with insurance or trying to get the patients back to a safe, comfortable environment, reducing the chances that they experience these issues. Other simple interventions, right, go back to the ABCs. So you have to be aware of it. Are you someone who's at risk? Is a colleague at risk? You have to drive balance in your life to be able to provide care for your patients. And then connection. Who is around to support you or for you to support? So I think just in summary, this exists. You may not see it, but you have to look for it. The reality is that many of the people that are caring for patients have either symptoms of or potentially are at risk for many of these effects. Attend to self-care. We've talked a little bit about it earlier in the symposiums this week. Take care of yourself both emotionally and physically. One aspect that is well talked about in the literature on how to prevent vicarious trauma is avoiding things like the media, Twitter, social media, where portrayals of these have been shown to increase the impact of the exposure to a trauma. Maintain important contacts, both colleagues, friends, and family. Focus on your strength base. Don't give up on hobbies, life events, and things that will keep you well psychologically and physically. And then talk to others. Our program at the University of Chicago has a program called Perspectives, where faculty and staff can easily interact with professionals in the field to just talk about the events, get some help with this. because it's a real problem. Thank you.
All right, good morning, AOA. It's great to be here with all of you. Of course, I'm not an orthopedic surgeon, I'm a trauma surgeon, but I have the privilege of working with so many of you in the specialty to care for injured patients, as Dr. Ficky mentioned. And I just wanted to say it's an honor to be here because we couldn't do what we do for these patients without the expertise and leadership in this room. It's absolutely fantastic. I'm going to give a little bit of a 30,000-foot perspective of what's happening around this public health crisis and really the role of healthcare professionals beyond the bedside. And what we do clinically, of course, I think all of us became surgeons because we love taking care of patients, we love operating. And I think what we started to see is that there is potentially an opportunity and maybe even a responsibility for us to think beyond the operating room, beyond the trauma center. And I just want to start by recognizing Dr. Preston Phillips, who you're going to hear more about from Dr. Ficky, but he was someone who, of course, was a member here. He was friends to some of you and incredibly beloved. And I think that this demonstrates to me and should demonstrate to all of us the fact that none of us are immune from this public health problem that we're facing. And if one of us is not safe, none of us are safe. And we're going to talk a little bit about that. I can't really begin talking about this issue without telling you my own personal story. So I'm the son of immigrants. My parents came to this country kind of in search of those hopes and dreams that I think so many of us strive for. And I think what none of us ever expected was at the age of 17, I would go from being this healthy high school senior to collateral damage after I was shot in the throat with a .38 caliber bullet. And, you know, I don't know how many of you were at the age of 17, but I would submit that most of us have no idea what we want to do in life. Most of us don't even realize that we're mortal. And that was really, of course, a life-changing event. And so I start with these two individuals that you see, Dr. Bob Ahmed on the left, who was my trauma surgeon, and Dr. D. Mukherjee, my vascular surgeon, who repaired my carotid artery. I had a ruptured windpipe and an injured carotid artery, and I have a paralyzed vocal cord, which some of you maybe can hear a little bit of my raspy voice. And these two individuals, along with their team, provided me with really a second chance. And as I left the hospital a couple months afterwards, you know, I had a tracheostomy, I had these beet red scars up and down my neck, and I was standing in the bathroom looking at the mirror, and what I didn't realize is my father was standing in the corner. And I think, like most dads, he saw that look of devastation in my eyes. And he came in and he said something that really kind of changed the course and the trajectory of my life. He said, "Joe, look, what happened to you was terrible, but you have two options. One is you can either feel sorry for yourself, which I think is tough love, especially from an immigrant dad, or the second is you can take this terrible incident and turn it into something that impacts the lives of other people." And that's really what inspired me to go into medicine, what inspired me to become a trauma surgeon. And at that time, my primary goal was literally just to be able to operate and give others a second chance. And you'll see how that path a little bit changed. So I just want to recognize, you know, my family. We each have loved ones that literally are there through the good times and the bad. We wouldn't be here without them. And of course, this is probably a whole different talk, but I had an opportunity I was taking care of it at Nova Fairfax. I went back there as a general surgery resident, and to have a chance to operate with the people that save your life, it's hard to even articulate what that means, but it was amazing. And when I left, I ended up going to Philly, where I spent a couple years at the Trauma Center at Penn, where I began to really understand the systematic approach to caring for injured patients. And as I was going through this entire process, what I started to think about were those patients that were coming into our trauma center that really we couldn't do much with. And it really reminded me of this motto, that we have at the Bloomberg School of Public Health, which says, saving lives millions at a time. And I think this motto reflects both, again, the opportunity and responsibility we have to think about this from a public health perspective, similar to what we've done with other public health problems. And it's what really took me to the Kennedy School, where I spent a year understanding the public policy aspect of this, because really trying to build up those theoretical skills were critical if you want to navigate that intersection of medicine, public health, and public policy. And I was fortunate enough to really combine all of that just before COVID, where I spent a year in the US Senate with Maggie Hassan, who some of you may know serves on both the Health Committee and the Finance Committee. Those two committees are critical because they essentially encompass all of healthcare jurisdiction in America. And there was a lot of lessons to be learned in kind of that year that I spent with them. But I think perhaps the most important was the fact that we, as healthcare professionals, as individuals that understand the front lines, are critical to this process. So I just want to recognize there's so many mentors that kind of get us here, right? And I'm so grateful for all of them. But there's also what I've been calling reverse mentorship, right? The people that are, coming up behind us that sometimes we don't realize are mentoring us, but they are if we're willing to listen and really listen with the intent to understand. So just a couple disclosures. I am a survivor, so I always say that because I want to recognize my own implicit bias in this discussion. I'm also the incoming chair of the Brady Board, which is a gun violence prevention organization, and I care for injured patients like many of you, so this is personal. So I put this picture just to make a couple points. I was in the fire department when I was in college, and it was an incredible experience. Now, some of you looking at this picture are probably like, okay, there's Joe, another photo op as the building behind him burns down. Now, the reality is that this was a training exercise. So we had just come out of the building as the other team went in. And I mention this only to make the point that when we are talking about difficult, complex issues, we have to be able to listen really with the intent to understand all the sides, to be objective, to really be dispassionate and remove our emotion from what the data is and how we build on the commonality that exists. I'm willing to bet so many of you in here have been in meetings, you hear someone that says something you don't agree with. Think about what happens at that moment. You stop listening to them. 90% of communication is nonverbal, so they kind of pick that up and they kind of, stop listening to you. And communication breaks down, not just for that one moment, but for future interactions, because you remember, oh, that's the person that said something I didn't necessarily agree with. So we just have to do a better job, I think, recognizing that as we deal with issues. So this is, a very common page that we get at Hopkins, right? Gunshot wound to the head. This was a 16-year-old kid that came in, and he was a GCS 14, alert, talking to us and everything. And you can't see the full scan, but what I can tell you is he had a devastating injury that went through the sagittal sinus. And at that moment, when I saw that, what I recognized was he didn't have a lot of time. And there was probably very little that I could do. And what I tried to do at that moment is actually find his parents so they could spend any last few minutes that they had with him. We're going to come back to this a little bit later. We already heard about the increasing toll, right, of gun deaths. You may not be surprised, and I'm sure you've heard that gun violence is the leading cause of death in children and adolescents in America. Think about that. It's not poisonings, it's not car crashes, right? It's not cancer, it's gun violence. And when you look at this and you break it up across gender, age, right, and race, there's something that is incredibly important, has to be recognized. Initially, some of you may look at this and say, okay, well, that's not too bad. It's 4.5 per 100,000 across all comers. Well, when you look at white males, you see that number drops down. What happens when you look at young white males? We know that trauma is a disease of young people, so we see that number goes up. What happens when we look at black males? What happens when we look at young black males? So the point here, and this is so critical, is often there is significant amount of media attention, right, that is around the mass shootings, which we'll talk about in a second, that happens. And of course, it's important to prevent these mass shootings from happening. But as you heard earlier from Dr. Miller, that is less than 3% of the overall public health problem. And in fact, every day in cities like Baltimore and St. Louis and Chicago, young black men are being slaughtered on our streets. And we have a responsibility to tell those stories. We can see here what's happened in Baltimore, right? 8-year trend, over 300 homicides. And we didn't really talk about this yet, but it's not just the homicides. It's also the non-fatal injuries. For every death, there's about 2 to 3 non-fatal injuries that happen. Why is that important? Well, it's important because we know that in many communities, the recidivism rate, meaning the risk of that person coming back with another injury, can be 40 to 60%, right, over 5 years. So there's an opportunity for us to intervene there. The mass shootings, which are defined as 4 or more people being injured or killed, you can see have continued to go up. Now, like I said, it's the minority of the problem, but it's allowed us to get a lot of media attention, which indirectly we have been able to, I think, use and leverage to pass and implement programs and policies that have been effective. I think I told you this is personal for all of us. You know, we were talking about Dr. Phillips, and you're going to hear more about Dr. Phillips in a little bit. But I just want to share something that happened last year on April 1st. I was walking into the hospital ready to take call. It was 6:55 in the morning. And my partner called me and said, "Hey, Joe, one of our partners has been shot. He's on his way into the trauma center." Okay? Some of you may have heard about this. Literally, one of our trauma surgeons, someone who is taking care of injured patients, is on his way into work and gets shot. And I don't know if some of you have had to take care of loved ones or colleagues, but all I can tell you, if I'm being completely honest, is in that moment, I honestly didn't know what his injuries were, and I didn't know if I was going to be able to separate the emotion from the business side of what we have to do, which is make one methodical decision after the other to save that person's life. Now, luckily, physically, he's doing okay, and he's, of course, dealing, I think, with the psychological and mental trauma of this. But this impacts all of us. We've been talking about this as a public health problem for over 10 years, and finally it's starting to catch on. And what I'll just tell you is there's this thing I call the myth of mental health, and I think this is so important because people chalk up what's happening always to mental health. People with mental illness, one of the major kind of diagnoses that you see here, are more likely to be victims rather than perpetrators. Now, it's all about how you look at the data. We know that 54% of deaths are suicide related. So if we're specifically talking about suicide, there's a high correlation between mental illness and suicide, and that's very well demonstrated in the literature. And you can see that it affects a different demographic, right? Primarily older white men. But it's also recently been shown to increase in young people, especially Black, Latino, and Asian teenagers, where there's been an increase of over 120% in the past decade. Our veterans, right, you may not be surprised, and I think a lot of you have heard, and we know Dr. Fickey's a veteran, and I'm sure some of you in this room are, that we lose 22 plus a day that die by suicide. You may not know that 70% of them are firearm related. And why is that important? Well, it's important because the case fatality rate is so high. And here's, I think, the thing that we should all take away is people that survive a suicide attempt, okay? This is a great study that followed people out for nearly 4 decades. Guess what? They don't go on to die from other issues or another second attempt. They go on to die from heart disease and things that probably a lot of us will succumb to. So that's an important thing. And if the mechanism is a firearm, the reality is that they may not have that second chance. We know that from the time someone makes the decision to die by suicide till that first attempt, 70% happen within that first hour. So why do I mention this? Well, that's important because after someone has made the decision, it's probably too late for us to intervene, which is why things like extreme risk protection orders, right, where we can empower the community, the family, the friends, to be part of the solution in this problem is so critical. I think a lot of you have probably seen there's a new hotline, the Suicide Crisis Lifeline 988. I think this is going to be revolutionary. There's still a lot of glitches that are being that we're working on to fix this, but I think this is going to be phenomenal. Now, this also impacts intimate partner violence, and some of you may not be surprised to hear that if the perpetrator has a firearm in the home, right, the partner has a firearm, it increases the risk of death by 500%. And in fact, one woman is fatally shot every 16 hours. So what I'm trying to demonstrate here is that this is impacting so many different walks of life that we're a part of. Now, if the human toll is not enough, let me just say that there's an economic burden that exists, right? We did this study looking at charges, both those that were discharged from the emergency department and those that were admitted, and you can see that it's about 5,000 if those are discharged versus 100,000 for those that are being admitted. We extrapolated that to about $2.8 billion a year, right? Now, you have to be careful with numbers because that $2.8 billion is not the societal cost. That's simply like hospital charges. When you look at societal cost, there's data that has it above $550 billion. What does societal cost mean? Well, it means being able to go back to work, having to be on a ventilator for life, all of these different things that happen outside of the hospital, which frankly we as a healthcare system are not very good at being able to take care of. So I hope you've seen that gun violence is a public health issue, and like other public health issues, right? When we were trying to face motor vehicle fatalities in the 60s and 70s, we didn't get rid of cars. No, we came up with seatbelts and airbags, and we made roads safer. It's about developing a system that makes it less likely for people to be injured versus simply trying to focus on human behavior alone, which we know is not cost effective. We've written a number of pieces that also talk about the structural violence that is existing in cities when you think about the discriminatory policies of the past, like redlining and some of the ones that you heard Dr. Miller mention. The reality is that only policies can fix what policy has created in the first place. We have the responsibility to think about how we look at this from a structural problem, because it's not only gun violence that's impacted, it's so many of the other components. Now, last year you heard that the Bipartisan Safer Communities Act was passed, and that was an incredible step, even though it took nearly 30 years at the federal level to finally get something done. Is this the end-all be-all? No, but this is an important first step that will help save lives. And I say it's a first step because the reality is there's no one solution to this issue. In order to really tackle this issue, we have to have a multifaceted approach that cuts across different disciplines. And I'm going to say something that some of you may find controversial. This is not just a public health issue, but this is a national security issue. There are literally countries that are giving their citizens warnings about coming to the US because of the risk of gun violence. In fact, if you come from certain countries, your risk of gun violence increases by 1,000%. So you could imagine that if 100 plus people were dying a day from a foreign actor, how quickly we as a nation would act to fix this. What happens at the community level is also so critical, right? Because the reality is that sometimes we sit in these ivory towers thinking, that we know the solutions and what the community needs to be doing. But the people in the community, those that are closest to the struggle, they know the solution. And they have to be real, true partners and stakeholders, not just an afterthought where we come to them and say, hey, you should do this. And that's what we've tried to do in Baltimore, breaking down the silos that exist between healthcare, businesses, the public health department, and so forth. So we've also discussed, this is a piece we wrote in JAMA to really talk about, well, how do we coordinate what's happening at the local and state level with the national level, and really kind of describe the process of developing an office for national violence prevention. I'm not going to get into it. We can talk about that during the Q&A, but again, we have to be able to link up all of these entities if we're going to have a really kind of a streamlined approach to this issue. Now, I put this slide together a couple months ago, and I put it together because I kept going back to the issue of, well, what is the core problem? What's the core issue? And at the end of the day, it comes down to easy access of a firearm. So if you think about this, if you take easy access and you add hate or impulsivity or any one of those listed above, it can end in a very deadly situation or with someone being injured or someone being disabled, right? Other, nations have mental illness, right? Other nations have violent video games, but they don't have the issues that we face. As we think about the cultural transformation that has to happen, one of the things that we've been doing is we created a Hollywood Committee on Guns. And what we're doing here is we're trying to work with the entertainment industry to really incorporate aspects of gun safety into TV and film. Now, the goal is not to get rid of guns out of TV and film, right? We don't want to impede the creative ability of our directors and our writers. But as an example, instead of the actor putting the firearm on the table, they put it in a locked box. When you think about other public health problems like motor vehicle fatalities, think about what an actor does when they get in a vehicle. The first thing they do, almost always, is put a seatbelt on. That's not a coincidence. That's been baked into scripts over decades. This doesn't change anything overnight, but it will help from a social norm perspective, I think, over years. And we just took a bunch of, this is a picture from, we went to the White House and met with Ambassador Rice, and we met with Steve Benjamin, who's the Director of Public Engagement, to talk about this issue, and now we have a couple working groups that are hopefully going to help move some of these issues after their strike, of course. So I'm just going to end, because I know I'm close to short on time. I just want to talk about an aspect that, when I first talking about telling your story to surgeons, I got a lot of funny looks. People were like, oh, those are soft skills, like this is ridiculous, what are you talking about? And I think now people have started to realize the power and the impact of being able to communicate our stories. And I think about my professor from the Kennedy School, Marshall Gans, who's probably is the world expert in public narrative. And he talks about it in the terms of the story of self, the story of us, and the story of now. And the point that he has is if you're going to go from value to action, it's done through emotion, through being able to tell your story. The data and science is critical, but I think all of you know that data and science doesn't change the hearts and minds of people, right? And so regardless of whether it's this issue or other things that you as an organization or as individuals are passionate about, being able to do this in a way that allows you to kind of hook that person and make them understand why it's so important is critical to success. The right idea alone is not enough. You have to have the right strategy and approach. And some of you may have listened to this TED Talk by Simon Sinek, The Golden Circle. He kind of talks about the why, the how, and the what, and it goes back to the same thing we're discussing, which is if you want, if you think about really successful companies, right? The reason they're successful is not because they tell you how they're going to do something. It's because they get you to believe in what they believe in, and that's the why. So, I saw the survey where some people didn't think, I think 11% didn't think that, healthcare professionals should be involved in this issue. What I would say is that there are a lot of healthcare professionals, especially the next generation of healthcare leaders in America, that think not just this issue, but a lot of the issues we're facing are important for us to discuss. And this is a piece where, some of the trauma surgeons from Philly talked about an apolitical profession waking up. We've talked about this in different ways also and written pieces, so we can help demystify for the American people what we are seeing, in our trauma centers and our operating rooms. We recently did this piece with the Washington Post that demonstrated kind of the blast effect between, high-powered rifles like AR-15s and handguns. And I think all of these together is just a demonstration that there's no one right way to try to get the message out. It's a multitude of steps. Some of you may have heard that in 2018, the NRA came after us as doctors and said we didn't have, any business kind of being, part of this solution. And I think there's something that's very important to say about this. Two things. People always get nervous when I talk about the NRA. It's two things. One is the leadership of the NRA doesn't represent the membership. Okay, most responsible gun owners, some of which are probably in this room, agree with the majority of the common sense solutions that we're talking about. And that commonality gets missed. The second piece is that for any person or for any organization to think that we as healthcare professionals, those that are at the center of taking care of these patients, are not part of the solution, either don't understand the complexity of the problem or don't really want to see it change. So that led to a couple very important things that Dr. Ficky's going to mention as well, but we had essentially an inaugural summit that brought together 46 different medical organizations across the country. That first summit was really important because it kind of laid the groundwork for the foundation of a public health approach. We recently had the second summit, which happened in September, and this wasn't a summit just to talk about this issue, but it created 4 different working groups that are going to cut across the organizations, and you can see them listed here. So, I never realized the power of my own story, and part of that was really happened when I was in Philadelphia. We used to bring these kids in, and we would talk to them about gun violence, right? And what would happen is, the first time I did this, I'd give them a tour of the trauma center, I'd bring them in. They're 14, 15-year-old teenagers. And the first time I did this, I hadn't told them my story. So they're kind of listening to me, but not really, right? Typical teenagers. And then I told them my story, and when I did that, there was a reaction that happened that I didn't expect and had never seen before. It's all of their eyeballs focused on me. And I think what it taught me in that moment is I went from being this guy wearing a white coat to someone that could relate to what these kids were facing in their communities. So I think all of us, Marshall Gann says, if you're in public life, you have to learn how to tell your own story. I think we all have to learn how to tell our own story. And I'll just leave you with this, is the community is so critical. Regardless of the social issues that we are facing in America, they're so interconnected to health. And we are, I think, in general, trusted public messengers. And we're part of the social fabric of the community. So we have a responsibility to be able to do this in a way that's effective. I'm just going to skip this because we're a little bit over time, but I just want to leave you with a couple things. First is, what's your story? And, my dear friend, Gabby Giffords, I think we've seen kind of the moral courage that she's had despite her devastating injury to continue to try to move this needle forward. And I think we all have to have that moral courage. I love what I do. But the worst part of my job is having to go into a waiting room and to tell a mother or father that their child that left that morning is never coming home again. And, I had this one instance that happened a couple years ago that I just continue to think about. There was this mom of a 17-year-old that the kid was shot in the head, devastating traumatic brain injury. And I had to go up and explain to her, the scenario. So I go up to the ICU. In our ICUs, we have these glass doors, and I could see the mom standing at the bedside holding on to her son's hand. And I walk in with the team, had medical students, residents, and some of the nurses. And I began to explain to this mom the devastating injury that her son experienced. As I began to do this, she began telling me about her son, how he was the first in their family to graduate from high school, which in Baltimore in the Black community is a big deal. He had hopes and dreams of going to college, none of which will ever come true. And as she did this, she looked up at us, and I think she saw how we as kind of the healthcare team were emotionally impacted by what her son had just experienced. And she came over and she did something that I'll never forget. She put her hand on my shoulder and she said, "Are you okay?" I just want you to think about that for a second. Here's a mom that just lost her son, and she's asking us if we're okay. It's moments like that which restore my faith in humanity, and it's moments like that which get me to wake up every morning to try to do everything I can to make communities safer. I want to thank my partners who are doing the hard work back at home, and that's why I'm able to be here. And of course, I want to thank the AOA and just recognize Dr. Phillips. We are going to miss him. Thank you so much. Thank you. Thanks.
Thank you, Joe. I think first it's just a privilege to call Joe a friend and have him with us. Just share the commitment that I got a call yesterday afternoon. There was a storm in Charlotte. Joe might not be able to make it. And there's no way that anyone can give that talk. There's not someone in this organization that can give the talk that Joe just gave. And I just want to thank you. He did a lot of finagling and detours and everything else to be here. I think he got here at midnight last night with it. So, and it's also self-induced injury that I put myself at the end of this after Joe to talk about this. So bear with me. I have no conflicts to this particular presentation, but I am disclosing that I am a retired military veteran with 30 years service. I own a firearm. I've owned several firearms, and I'm on the firearm safety team for the Committee on Trauma. And I too had this as our lane on my banner for social media because we're in it together. And so just gestalt these next 3 slides. These are the mass shootings that have occurred so far this year in 2023. And these are the total injuries. And we've already heard that most of these are suicide attempts, several children, many women. This is the scope of what we are talking about, the injuries as well as the mortality. These are the fatal shootings in similar distribution, but look where they are, east, south, across the country, where they happen, everywhere we are. And I want to talk about Preston Phillips. This seminar and this symposium was put together after Preston died as a result of a mass shooting on the 1st of June. Preston was from Tulsa, Oklahoma. Preston was born in Minnesota, and he was raised in a family of 9 children. He went to undergrad at Emory, and he had a brother that followed afterwards and said, I'm only getting 1 degree. And in a celebration of his life, just celebrated that Preston played ball. He was an athlete. He was a scholar. He had a bachelor's degree in theology. He got a master's degree in organic chemistry, and then he became a White House fellow. He went to Harvard Medical School, and he went to Yale for his residency, and he did his fellowship at Beth Israel and at Boston Children's. And he practiced spine surgery. He practiced international orthopedics. He practiced caring for human beings. He was a member of the AOA. He's a fellow. He was also member of the J.R. Gladden Society and the Scoliosis Research Society in the Interurban. And these fellowships and friendships are the reason that he is so loved and so missed and is a pillar for our organization this year. He did missions in international in Tonga, and he also did missions at home in the Franklin Center for Reconciliation for Violence and Education within his hometown of Tulsa. He's survived by Melody, and he's been a friend of all of us. And if you didn't know him, I hope this helps you to understand, and I credit some of my friends, Val Lewis and Eric Carson for sharing some of their experiences with him. And why are we talking about this today? The 4 of us live in cities that are of the highest violence, from St. Louis to Chicago to Baltimore. We experience violence every day in our trauma centers, but we saw from those previous slides that everywhere we are in this country, we're exposed to risk. And I want to credit Julie Samora and Brent Ponce and Josh Pat for conducting a survey of our AAOS members. And that's the final manuscript of that is coming out. But roughly 3/4 of us, of the membership that's responded to the AAOS survey, have experienced workplace violence. So this is relevant to all of us. If you're Black in your lifetime, you have a 99% chance of being exposed to someone who was impacted by non-fatal violence, a gunshot wound specifically. 95% of a fatal one. If you're white, non-Hispanic, you still have a significant risk, and all of us have that because we knew Preston Phillips. 99% of all comers are going to have some exposure to a gunshot injury. And the truth of this is that close to 50%, 45% of our population owns guns. So we did a survey beforehand, and Anna showed the survey, the respondents. And most people think that advocacy and national policy will help. And you saw very eloquently what Dr. Saccharin showed of the actions that are taking place. But I want to talk about how we, as physicians who care for patients that own or don't own guns, how this is seen and how there's a bridge between these. So about 50% feel that there's a benefit, and this is a right based on Constitution. About 30% have no opinion or feel that there's slight risk, but about 8% feel that there is a significant risk to their liberty and to the safety of their people, their patients, and their family. So this is a slide that I'm going to illustrate, but I want to just get a picture of two opposing views. Those who believe firearms are dangerous and those who believe firearms are beneficial and essential to our culture. This common narrative that liberty is protected, that violence is preventable, and we can work together, we should work together to reduce death and disability. We should understand the underlying causes, which we've done in this panel today. And we should talk about ownership, making it as safe as possible. And so the firearm safety team was commissioned by the Committee on Trauma to look at this as a group of individuals, 18 individuals that were firearm owners that are also trauma surgeons. I served on that committee, on that group, and we worked over several in-person visits to understand what was common. What could we agree on as firearm owners that share that common narrative? And this is important to understand that common narrative is an aspect. And so we came up with some conclusions that we agree. Tactics to increase firearm safety, to reduce the probability of mass shootings, to reduce firearm-associated violence, and to address mental health factors. While we have seen a recent increase, industry or funding for research around firearms has been the mainstay, and federally funded research is essential while we preserve the right to own a gun. So this is a public health model that Joe has talked about. The upper part of this triangle have to do with clinical interventions and education. That's what we want to talk about because, as Joe has also showed, and the group has shown, that public health related to seatbelts have reduced fatal mortality, fatal injuries from motor vehicles over a substantial rate. So these three conferences came together, and there's 10 recommendations, but most important, I want to talk about three. Controlled storage, see something and say something if you notice, because as we've seen, mental health has a low rate of impact on homicide that we can intervene, but it has a substantial rate on self-harm or suicide. And then I want to talk about healthcare communication. So these are my modes of protection in my home. Trigger locks, barrel locks, secure anchored storage, far from anyone who's going to see this. And the slide on the right, I want you to know, is a survey done of gun owners, and recognizing that people recognize the NRA as an authority versus physicians in a substantial way. This was 2016 data, but if that doesn't change, then we have touches to people who are going to be impacted by this. So the firearm conversations are not different than when we ask about smoking or health-related behavioral modifiable risk factors for outcomes. And so asking about firearms should be no exception. When surveyed, most people don't, most physicians don't, and they are concerned about it being legal. I'm here to tell you that the restraint laws on, or gag laws as they're known, requiring you not to ask your patients, or they're not active, they've been deactivated with it. There are 5 simple questions, and I think about 5 L's. Do you have a gun? Is it loaded? Is it locked? Are there little children present? Are you feeling low or down? And what have you learned about firearm safety? Can you be educated? This is just to amplify what Joe talked about with the culture of violence. The movie industry is moving away from firearm violence being something that's acceptable, similar to what they did with cigarettes. In 2001, Malcolm Gladwell published a book called The Tipping Point, and he talked about the effect of suicide and public noticing of suicide and media impact. And in 2012, this was an article that was published in The Atlantic that looked at how media could impact this. And this is a quote from an expert panel in last year that looked at the media was barely able to maintain coverage from one event to another. And maybe we need to look at this, not restricting the right to the free press, but how do we modulate that so that the culture of violence is not celebrated? The techniques and instruments that were used are the name of the shooter, and we made specific recommendations about this. So we have extreme risk protection orders that are increasing across the country. Just 2 weeks ago, Michigan Governor Whitmer signed into law the extreme risk protection order in Michigan, followed by Minnesota, and these are expanding. But our passion is to prevent intentional violence. And this, there is supposed to be a book here that fell out in the translation, but the book called Choosing Civility is relevant to our disruptive physician conversations we've had. It's relative to this conversation because PM Forney in that book described at least 2 ways of showing disrespect for others who do not share what you think. One is to tell them their opinions are crazy, stupid, worthless, or the like. And the other is by assuming that what we think must be right, and therefore you should come to my views. So incivility, in the language of disrespect, is the foundation and the precursor to violence. For discussion and conversations, and I'll invite people to the audience, up to the mics. Violent intentional injury is the most poorly addressed public health problem today in America. There are 2 polar perspectives. Where are our common values, our common areas of interest, our common connections? Share those through the stories that Joe talked about. This violence tragically impacts our patients, our communities, our profession, and ourselves. And it requires partnership. And it requires us to act. We can act in our clinics by asking patients. We can listen to patients' stories, we can understand their perspective. We can speak with our partners and our patients about our own wellness. The self-harm that we've seen, the emotional injuries, the moral injuries that our physicians, our partners see. And finally, learn some available resources that we've shared with you. So I so much appreciate that you're here and that we could do this. I appreciate Dr. Goldfarb and the planning committee to have this. So what questions do we have? Please come to the microphones.
That was truly a fantastic presentation by all. And, you know, the one thing that we did not really enlighten kind of the audience on is our personal biases towards trauma patients and those patients who are poor in these socioeconomic communities. That in itself brings forth, and I think the gentleman from the University of Chicago said it very well. Selwyn Rogers is one of my mentees, just an incredible individual, and, you know, being Black and being in these trauma situations, we do show lots of empathy. And I would just ask all of you all to understand the differences that those bring forth some biases. So for instance, we talk about pain. There's been plenty of articles written about African American patients don't exhibit the same amount of pain. biases towards, the surroundings that they live in. All of those affect the care that you provide to these patients. So I would just say, from my perspective as an African-American orthopedic surgeon working in this situation, as Selwyn has alluded to, understand that these are things that, biases that are expressed, but not intentional.
Thanks, Dr. Carson. Anybody want to comment? I think we all fully agree. Dr. Cates.
Yeah, thanks for a great symposium. In my institution, we've had a murder in the hospital in the last 3 weeks. One employee shot and killed another. And we've had numerous shootings on campus just this month. How do we prevent or reduce this actually in the hospital and on campus?
Great question. Who wants to take that?
Yeah, so it's okay. I got it. Thanks for bringing that up, and I'm sorry that you all experienced it. The reality is it's a lot more common than we think, and there have been a number of hospitals and healthcare systems that have been experiencing this, especially recently with what we've seen. At Hopkins, I can just tell you that we've had this discussion about what is the right path. Do we put up metal detectors at every entrance, right? Which we haven't done. We have it in certain places. How do we ensure that we are doing everything we can to not just keep our patients safe, but also to keep the healthcare workers safe? And you may have heard just a couple weeks ago, it didn't make a lot of news because no one was shot and killed, but a trainee came into Mass General with an assault rifle, getting ready to kill as many people as they could, and fortunately the attending was able to talk that person down. So I back to your question. So I think what we have to do is really think about the public safety departments that we have within our hospitals and healthcare systems, and every institute is going to be a little bit different about how they invest in that. In Baltimore, there's a lot of controversy where there's an effort to try to have a Johns Hopkins police department that is literally on site and part of kind of the fabric of our employees. But there's a lot of controversy about the university investing in that. And so it's a difficult kind of scenario that I'm not sure really has one right answer. It probably is a multitude of steps, and it probably has to be tailored to the environment and to the culture that you're living in. I don't know if you all have any thoughts about that.
I think those are all great points. Is this working? Yeah. I would just add that I think it's really important to not be reactive. We had an incident in the OR where somebody had a gun in their bag and the gun went off and shot the wall of the OR. Luckily, nobody was injured. But immediately the OR had all these signs up about not bringing your guns in the OR, which doesn't really help much. But, I think your point is really well taken, that you need to have an institutional discussion policy, really thoughtful way of proceeding. And also just add that when those things happen, I think it's really important to address the mental health aspects, because even if somebody was not injured or not murdered, that doesn't mean we don't have all these bystanders and the fear of coming to work and the PTSD that's happening. So make sure that mental health part is part of the response.
Yeah, healthcare professionals, as probably everyone here knows, are at a higher risk of mental health illness and more often die by suicide than the general population. And that's definitely, I think, part of it. And I think part of it relates to, Jim, what you were talking about as it relates to the burnout. And I think you mentioned this as well, kind of right, that emotional, that second victim kind of stress that happens and that we see.
I'm going to go to center mic, and then front and then rear back.
Laura Randall, Sacramento. Thank you for a impactful presentation by all of you. And Joe, I want to thank you for sharing your experience. I'm going to take a moment to share my experience, which I tend to keep private, but I thought it would be helpful to just bring it home. So my father tried multiple times to take his life. And in fact, one time when I was a kid, I was playing hide and seek with friends, and I went into our guest closet, and he had a bag over his head, a plastic bag. He ultimately got access to a firearm and took his life. Fast forward to my residency at UCSF. My senior resident was very distraught. We used to stand out on the ambulatory clinic overlooking the Golden Gate, and he just would say to me, I'm not sure I can keep going. This is just too hard. It's too tough. He'd worked really hard. About a week later, he'd taken his life, left his wife and kid behind. Preston Phillips was my resident when I was a medical student at Yale. And he, with Uli, both the spine surgeons probably know Uli, a wonderful, wonderful person. Uli was the chief, Preston was the junior, and I was the med student on the service. Preston was at the scrub sink with me. Uli was already in the room. And he's, we all know Preston, big, burly guy. He said, what's your name? I said, I'm Laura Randall. I'm the sub-intern. I'm really excited to be here. And he goes, well, let me tell you, Laura. And then we're starting to scrub. What we're going to do here, I'm going to get this plate on this broken fracture, and I'm going to hand you a drill. You're going to take that drill. Don't let your hand shake. And you're going to push really hard on that first. When they put it up into that hole, you're going to push really hard. Put that screw in, or you put that drill in, but be careful. When you get to that second spot, back off. Don't plunge that far side because the vessel's on the other side. You don't want to plunge that drill. And he would walk me through it, and then he coached me afterwards. And then through the interurban and the AOA, he and I, with Gus White, would talk about a lot of the issues that are facing all of us today now that are more poignant than ever. But these three experiences in my life drove me to want, as a physician, to manage death in some way, be a steward for people who are facing their mortality. I thought about a trauma fellowship. I was thinking about going to Harborview. It was just too personal for me with the guns. So I went into oncology as an orthopedic oncologist. But for all of us, I just want to take this, I want to encourage us all to take this charge. Our friends, our family, our communities are the most important thing to us, and we need to embrace this issue and find solutions. Thanks.
Thank you.
I'm Bob Slater, also from Sacramento. I want to thank the panel. We that don't do trauma surgery don't see this as often, but certainly, as you said, are exposed to it. So you all think about it a lot more every single day. What do you envision the solution to be? You've done a great job outlining the problem. It's devastating, and one thing would be to adopt that cynicism, which you pointed out is such an effective defense mechanism. Say, well, I'll just go to work tomorrow and fix all the rest of the problems. Is it going to be a legislative solution as you envision it? Education? What do we as doctors envision ourselves being able to do to change this problem? I'm interested in your thoughts on that.
How about Jason? You want to?
Yeah, I think I'll start by just saying you have to try and lose the cynicism, right? I think that's fundamentally you have to open your mind to the possibility that you can make a difference. I think one thing, and that early question about what our roles are, every single patient that walks through the door and every single patient that we look after, we have an opportunity to help and change. That's a simple thing, but the ripple effects are the same as being a victim or a survivor. So if you can change that one person's opinion, their outlook, their goals, and their trajectory, you've amplified the effect that you can have on the community. So I think personally, from a practical standpoint, the easiest thing that I can do is start there. I think there's a whole host of other things we can do, right? We can advocate, we can look at political solutions, legislative solutions, but I think fundamentally the only way that we'll make a big change is grassroots to start.
Can I just add real quick? I think, when you think about all of us, we're all a little bit different, right? And not everyone is going to be comfortable, or it's going to be kind of natural for them to do X, Y, and Z. Some people like to write opinion pieces. Some people, don't want to be involved in the space at all. But I think all of us can do something. And I'll just give you an example. There's someone that we work with who, like yourself, doesn't deal with trauma patients, but is a leader in the institute. And this person is like, okay, I don't know anything about this issue. I don't know how to solve it, but I can support, my junior faculty or my team, whether it's through, support through resources or, other different aspects. So they become part of the solution indirectly, which is also very impactful. And I think each of us, whether it's gun violence or other issues that we're passionate about, have to think about how can we be impactful beyond the bedside. And not everyone, that's not going to be for everyone, but if it's not for you, maybe you can support someone that is interested. Right now, we are having the next generation of healthcare folks in America that are incredibly interested in what I call these non-traditional kind of paths to medicine, so to speak. So I think it just depends on where you think your talent lies and how do you kind of leverage that in a way that can be effective.
I would just add, for the kind of socioeconomic side, it's really important to be involved in your community. We have multiple programs in St. Louis to help with recidivism, which is a huge issue in these patients, and helping them get out of dangerous situations and be in a better place. But we also have a history in the United States of not financing research on gun violence for many of the issues we've discussed, and that is actually opening up now. And we're starting to have more national funding and ability to do research and really get some of the answers to these questions, because part of it is that we don't know what the best ways are. And I think that would be another thing, just to encourage continuing to advocate for financing gun research, gun violence research, but also to get involved in your community to see what can be done for helping the patients after gun violence has occurred to get them out of situations where it could occur again.
So I'm going to take prerogative. So there's actions across this. I think the panel has strong feelings about it, and whether you're trauma or oncologist, who turns out to be the most common experiencing workplace violence, you have patients that don't do well. I mean, maybe you don't, but I do. And sometimes those patients that are not doing well are down. Are they low? Do they have a gun? Would they be willing to lock that gun up if they don't, or give it to someone else and ask some conversations about how they might be at risk to themselves? That's half the battle, and that applies to all of us, I think.
Yeah, hi. Great symposium. Milan San, I'm in the Bronx, and we do have hospital police in our hospital, and we had a shooting in our emergency room waiting area last year, so this resonates a lot. I have a question about how strongly a position our organizations like the AOA or the OTA, WOS, should take on the gun violence issue. So, I mean, Anna, we've sat in those health policy committee meetings, and my interpretation of the discussion is that there's a bit of hesitation on the part of these organizations to take too strong a position on gun safety for fear of treading into sort of the gun control waters. And so we focus on firearm safety, which is also important, and Jim, your talk was excellent, and Mike, you put a position statement on about it last year after the Tulsa thing. But most of the people on the panel, you talked a lot about firearm access. So, putting it all together, because I think at the individual institutions, we're going to look to the AOA and the OTA and other groups for guidance and leadership on this topic. How strong a position should these organizations be taking, understanding that if you do tread a little more towards a position on gun access, you're going to be alienating, a lot of the membership.
I'll take this because I've been at these consensus, and Dave Teague also was at both of the consensus sessions. We as an organization, looking at the leadership here, can be involved like these consensus in the way that we support it. And we can also discuss that common narrative that I spoke to, that we have more in common whether we're firearm owners or gun control advocates. It is a question that what is the what is the most interest of our shared interests? It is about reducing violence to our patients, ourselves, and our families. And so that's a common statement, and that's what you've seen. I had one slide that showed all three of those came to that group, and those are organizations: Pediatric, the AMA, American Bar Association, AAOS. So I think that, I know that we can do it because we represent a strong advocacy if we unite at the level of unifying for registration data. And the consensus of most firearm owners and the firearm industry, and if you want to look up a website, look at AFFIRM, AFIRM. They're working with gun owners or gun industry and working through this so that there's an approach that says we're not trying to take it away, we're trying to be responsible. So I think there's a whole lecture about this, but if you can, there is mixed feeling about within every society, that every organization that has been a partner for this, there's been mixed response. But there is a unified response towards saying we're all about reducing injury and in violence in the workplace and the community. So hope that helps.
Can I just quickly comment on that? I'm not going to comment on what the AOA should do, especially not as a member. But here's what I would say about organizations in general. There's been a change in kind of the comfort level that people have had, because I think, healthcare professionals realize, and the organizations realize in our discussions, that they need to be part of the solution. The question, I think, like you're posing is, well, like how aggressive, like our folks, right? And I think one of the things that's happened is starting to really kind of break down the misperception that often exists, which is, number one, that advocacy is like a dirty word. When people think of advocacy, they get really worried. They're like, oh, we're not, we're scientists. Like, we advocate for things all the time. That's number one. Number two is policy does not equal politics. So, some of us delve into both, but you could, as an organization, right, support data-driven policy, and concepts in a way that is apolitical and that's bipartisan. So I think there's an opportunity that exists, and I think it'll be up to the leadership and the membership to decide, what type of stance that they want to take on this.
And come up to this mic, Dr. Wright.
So, Rick Wright, 25 years St. Louis, 4 years Nashville. And the question's for Anna, but really the whole panel. Why St. Louis and Baltimore and not Nashville? It's when I moved there, it's palpably a safer feeling community, significant African American numbers, very red states, similar gun laws. And some of it, I think, Anna and I would probably agree that it's the city-county divide, metropolitan Nashville, Davidson County combined. They were the first combined city-county situation in the country, apparently. But what can we do to change this hopelessness that fuels a lot of this violence and no hope for tomorrow? So, this reckless life. And why is it so different in those two communities and similar communities around the country where it's not like that? Where I feel like, it's a big deal when somebody gets shot in Nashville. It's getting worse. We're smaller, but the growth, we're only about 500,000 behind in the metro area behind St. Louis now. So it's not just raw numbers. What can we do to change the St. Louis, Baltimores, and those few communities that this is such a huge problem for? It's really different.
Yeah, I think that's a great point, and obviously a really challenging problem to solve, or we probably would have fixed it already. But I do think it, at least in part, goes back to that history and the segregation that I was talking about. And if you look at the way the gun violence distribution is in these cities that did have the Great Migration and did have redlining, and there are distinct areas where the populations are socioeconomically challenged and have not had the ability to get that step up and back kind of on an equal playing field. So I know it's a really challenging topic to discuss, but I really think we need to have more of that looking into the structural issues that are causing these problems, and they really do seem to happen more in the cities in the north where people came back in those days of the Great Migration. So very, very challenging topic, and I don't know that I'm a policymaker enough to figure out the answers, but I definitely think it involves going into communities to help people and not just leaving it as is.
Thank you. I think at this point we've got to conclude our questions. I'm happy to talk with the two folks remaining off, but we appreciate everyone's involvement and commitment, and thank you for the opportunity.
So we're going to take a quick 10-minute break and come back for the presidential guest speaker, building a bit on this topic.